All right. So let's start with a brief review of mast cells. So mast cells are a type of white blood cell, right? And they're found mostly in the connective tissues of the body. And particularly, they're found near the boundaries to the outside world, where your body comes in contact with the outside world, given their actual function in the innate immune system. So this includes places like the skin, really any types of mucosa that touch the outside of the world, including the digestive tract, the mucosa of the lungs and the upper respiratory system, the mouth, the conjunctiva, the nose, and even the urinary tract. Although mast cells are best known for their allergy and anaphylaxis responses, they can also be primarily involved in wound healing. They can play a role in angiogenesis, in immune tolerance, defense against pathogens, and even vascular permeability, which is particularly important in migraine. So when we're talking about mast cell dysfunction, there's really sort of two major categories there. There's mastocytosis and mast cell activation syndrome, which are not quite the same here. So disordered mast cell activation occurs when mast cells are either, one, overproduced, so there's a lot more of them, or if they are a little more twitchy, right? If their activation is out of proportion to what it should be for a normal, healthy individual to maintain homeostasis. So in mastocytosis, these are rare conditions that include way too many mast cells growing unchecked. And that can include cutaneous or systemic mastocytoses, mast cell leukemias, sarcomas, and other related malignancies. Whereas mast cell activation syndrome is actually a relatively common group of disorders that have diverse causes that present with episodic multi-system symptoms as the result of excess mast cell mediator release. In other words, the mast cells are getting hyperexcited for whatever reason more than they should, and they're releasing inflammatory cytokines. Anaphylaxis is an extreme example of an inappropriate mast cell activation in this case. So when mast cells are activated, they release inflammatory chemicals or mediators in the form of degranulation. And a lot of the common mediators include things like histamines, which we all are pretty familiar with, leukotrienes. We think about that in the asthma world more than anything, prostaglandins, but also tryptase. And tryptase is really the most specific mediator, but it also can be a little more difficult to detect when we're looking for it clinically. What's really interesting is that you can have a trigger for mast cell activation or release of these mediators locally, let's say in the GI tract, after having a response to something that was consumed, a medication, a food. But what's interesting is that these mast cells can send distress signals, usually through the nervous system, that can propagate a neuroinflammatory response in other distal areas of the body. And that response can include mast cell activation in other areas of the body. And we'll see some examples of that here a little later. So it's not always just a local tissue reaction, but a local trigger can cause a systemic multi-system response. These are the most common mediators, again, released from mast cells. They include tryptase, histamine, proteoglycans, prostaglandin D2, platelet activation factor, interleukins, TNF-alpha. I worked with that one quite a bit in my rheumatology days, and leukotrienes. And you can see here, there's a lot of overlap in symptoms, but the symptoms are more than just what we tend to think of as allergy symptoms or allergic anaphylactic symptoms. There's easy bruising and bleeding, myalgias, vertigo, flushing, diarrhea, edema, headaches, brain fog, abdominal pain, bronchoconstriction, urticaria, fatigue, the list goes on and on. So quite a few different responses depending on the target tissue in which the mast cells are acting. So when it comes to triggers, we're talking about a situation again in mast cell activation where instead of responding to foreign triggers like we should with the innate immune system, we're a little more twitchy or a little more hyperactive in this case. And so really there can be all kinds of triggers, and really getting a good history can be important in figuring out the triggers for mast cell activation. So the presence of excess heat, that's of course at the top of the list because of the heat we're dealing with right now. Cold and sudden temperature changes can be triggers for mast cell activation. And I'm going to comment on that in a second. Stress, emotional, physical, pain, environmental stress from weather changes, pollution, pollen, pet dander, et cetera, can contribute. And when we talk about long COVID and or ME/CFS, post-exertional malaise is a metabolically stressful situation. And so you'll often see mast cell activation either be triggered or actually get worse and more difficult to control in that particular state. Exercise-induced urticaria or exercise-induced mast cell activation, fatigue in general, kind of along with the PEM idea, can trigger mast cell activation or worsening. Food and beverages are particularly common, as are medications and drugs. So it's always important to think about what's going into the GI tract. More interestingly, we used to kind of dismiss patients who would say, oh, I had an allergic reaction to smelling Pine Sol, or I had an allergic reaction or symptoms when my neighbor 2 houses down was smoking outside and I could smell it. I was extra sensitive to it. And it turns out most of those people that say things like that actually have mast cell activation. Venoms from insects or from jellyfish or from snakes can be a trigger. Any type of infection can be a trigger. And of course, that goes back to our idea of COVID-19. Mechanical irritation, friction, and vibration are triggers. So when you think of dermatographism, that's actually a kind of localized skin mast cell hyperreactivity. So a lot of times when I'm seeing patients and I suspect mast cell activation, I'll take a pen, take the soft end of the pen and make an X on someone's arm, on their back. And within 30 seconds, if you see sort of a raised erythematous itchy area, they definitely have dermatographism and may have some mast cell pathology there. And then sun and sunlight can actually trigger these responses. And I used to see a lot of patients referred to me for photosensitive rashes, please rule out lupus. And it turns out that when they have these reactions, they're much more ephemeral. They don't last nearly as long as you would see with a photosensitive rash in lupus. So that can be a sign that you might be dealing with mast cell activation as well. And I would say in my own life, it's been interesting. I received the 2 vaccinations for COVID-19 follow-up booster. And after that booster, I started myself having urticaria that is induced by cold. So whenever I rewarm and put pressure on an area, like if I was hiking in the cold and then get back to my car and sit down, I get urticaria on the back of my legs and buttocks, which are sort of consistent with these type of symptoms. So very common symptoms that you'll see when people have mast cell activation include, of course, anaphylaxis being the most extreme, lots of dermatological manifestations, which can include hives or other skin rashes, cardiovascular responses, unexplained dizziness, orthostatic hypotension, lightheadedness, syncope, fainting, rapid heart rate, chest pain, and even just low blood pressure, gastrointestinal symptoms, which can include diarrhea, nausea, vomiting, abdominal pain, bloating, and even gastroesophageal reflux disease or just dyspepsia in general. And of course, respiratory symptoms, which can include wheezing, shortness of breath, upper airway symptoms of nasal itching, congestion, angioedema. Among the vascular changes, we can see flushing of the face, neck, and chest. But we can also get some other less appreciated symptoms, including bone and muscle pain, osteopenia, osteoporosis, uterine cramps or bleeding, migraines, bone pain, etc. So moving on to the criteria for mast cell activation syndrome, we touched on this initially in one of our early questions. The first of the 3 clinical criteria for making a diagnosis include episodic symptoms consistent with mast cell mediator release affecting 2 or more organ systems, including the following ones: the skin, okay, again, angioedema, urticaria, flushing, dermatographism, gastrointestinal tract, which includes nausea, vomiting, diarrhea, and abdominal cramping, the cardiovascular system with hypotensive syncope, tachycardia, lightheadedness, and dizziness, the respiratory system with wheezing and other asthma-like symptoms, and the nasoocular system in this case, conjunctival injection, itching, nasal stuffiness, etc. The second clinical criteria for mast cell activation syndrome includes improvement of these episodic symptoms after treatment with medications that are designed to reduce these inflammatory mediators. So of course, the most common of these would be antihistamines, H1 and H2 blockers, as well as other histamine receptor antagonists, and even diphenhydramine or Benadryl. It can also be a response to leukotriene antagonists, particularly montelukast or Singulair. Response can be one of the clinical criteria here, and then mast cell stabilizers, things that are actually designed to prevent the mast cell from degranulating in the first place, such as cromolyn sodium or ketotifen. So response to any of these meets the criteria here, number 2. Then the third clinical criteria for mast cell activation syndrome includes elevation of a validated URAM or cyrinary marker for mast cell activation. So a total serum tryptase being elevated is very specific for mast cell activation. However, you'll find that since this syndrome is episodic, and since these tests are hard to run, they have to be handled in a particular way by certain labs, it can be, excuse my dogs barking at the Google Fiber people. It can be very difficult to have this test be sensitive. So while when it's positive, it's very specific for mast cell activation, the sensitivity can still be low. So a negative does not rule this out. We also can see elevation of plasma prostaglandin D2 or elevation of serum histamines. We can see urine tests such as the N-methylhistamine, the 11B prostaglandin F2 alpha, or the leukotriene E4 be elevated in urine. And then we can also find elevated mast cells in biopsy tissues of different tissues. So the GI tissue is a particularly famous one. If someone's had an endoscopy and they had random biopsies, often you will find that they are not looking for mast cells, but you can go back to that pathological sample and ask them to stain for CD117, which is specific for mast cells, and they can detect whether or not there are normal or abnormal amounts of those mast cells per high power field. And then I put a comment here at the bottom, not that it's part of the clinical criteria, but in clinical practice, to our idea earlier about whether or not we can manage this in a primary care setting. Empiric trials of therapy, when you have the right symptoms and the right clinical suspicion, can be somewhat diagnostic in that arena. So you don't always have to chase these lab tests. And in fact, in my own practice, I find that they're often more trouble than they're worth. And I would just give people with the right clinical suspicion empiric trials of antihistamines, of mast cell stabilizers, of anti-leukotrienes, watch their response, and then use that to further guide my clinical care. So what really is the relevance of mast cell activation syndrome to our long COVID patients? Well, acute COVID-19, as we know, creates a cytokine storm with rapid proliferation and hyperactivation of T cells, of macrophages, of natural killer cells. And there's this overproduction of over 150 inflammatory cytokines and chemical mediators that are released throughout the immune system and by non-immune cells. Mast cells are absolutely activated by SARS-CoV-2, and in the early stages of COVID-19, there were many practitioners who were treating with simple antihistamines, and were noting that their patients would improve their courses of COVID-19 faster and also seem to have less transition to long COVID. So this is a study where they looked at people, general healthy people or general controls, those who ended up developing long COVID, both pre and post long COVID symptoms, and other individuals who did not have long COVID, but did have known mast cell activation syndrome. What they did is they ran a questionnaire associated with mean mast cell mediator release syndrome. So this questionnaire is just a validated way of looking at mast cell related symptoms that are self-reported by people. And you can see here that the general healthy controls and patients with long COVID before they developed their long COVID illness had similar scores, whereas those with post-COVID or long COVID and those who did not have COVID but had a mast cell activation syndrome also had similar elevated mean mast cell mediator release syndrome scores. So certainly it looks like a lot of the symptoms of mast cell activation were occurring in these long COVID patients. Furthermore, that same study looked at spiderweb plots of mean mast cell mediator release in these symptoms. And you can see that the mast cell activation patients and the post-COVID-19 long COVID participants had very similar symptom plots, whereas the pre-COVID and general population patients had similar spider plots. So here we have a list of mast cell associated disease specific pain syndromes. mast cell activation and its common activators. This is not to be, memorized or delved into with extreme detail, but it's to point out that mast cell activation syndrome has a lot of associations with many other disease processes. Common ones that we see in mast cell activation and in those who ended up developing long COVID include fibromyalgia. Here they refer to it as bladder pain syndrome, but we usually see it as interstitial cystitis. Endometriosis is particularly common, as is chronic prostatitis. Migraine, vulvodynia is a really common finding, and irritable bowel syndrome in particular in the patients that we see. And here you can just get a sense of all the different mediators that influence release of mast cell activation and how it can be so multimodal in these patients, including estrogens, IgE, IgG, vasoactive intestinal peptide, venoms, CGRP in the neurological system, complements, chemokines, et cetera, et cetera. This is another image that I think is a little more simplified, albeit cartoony, talking about coexisting conditions we will see with mast cell activation. Again, ME/CFS is really common. There are a lot of patients with rheumatoid arthritis who are seronegative, who have biopsies of their synovial tissue that show increased numbers of mast cells. So there may be some association there, although we're still investigating that. Multiple chemical sensitivities, Ehlers-Danlos, idiopathic anaphylaxis, fibromyalgia, eosinophilic esophagitis. We see that a lot on EGDs in our patients, and early osteopenia or osteoporosis, particularly in men or in premenopausal women, are also very common. So here we are looking at POTS patients. And this was a study that looked at two different groups of POTS patients. Some who were considered to have normal, quote unquote, normal laboratory tests, and others who had at least one, if not multiple, elevated markers for mast cell activation, whether that be tryptase, histamine, and methylhistamine, prostaglandins, et cetera. So those are the ones that are labeled as abnormal laboratory tests. And what I think is interesting is not only do you see above the dotted line there that syncope, fatigue, palpitation, the symptoms, and lightheadedness and dizziness, that the symptoms were more prominent in those with abnormal laboratory tests than those who had been diagnosed with POTS without mast cell mediators. But you also see atypical symptoms in a much higher level, particularly the three I've circled here: migraines, allergy, and gastrointestinal symptoms among these POTS patients, compared to other POTS patients without these elevated markers. And then skin rash was also not uncommon, however, not as common as allergy, gastrointestinal symptoms, and migraines. So very clearly, there appears to be kind of two subgroups of POTS, those with mast cell activation and those without. And then here is from the same study, among those who had POTS with the atypical symptoms, the migraines, the gastrointestinal symptoms, and these elevated markers, you can see that the three markers that were most elevated were prostaglandins, histamines, and methylhistamine, whereas tryptase still was not very often found in these patients. So again, very specific, but not terribly sensitive. This is taking a look specifically a little bit at the topic that we discussed earlier, which was sort of the signal transduction of mast cells from one area to another. And this is kind of a specific example of how it can trigger other types of symptoms in distal areas. So for example, in this case, we have nociceptive inputs from primary afferent fibers, whether it be in the skin, in the GI tract, somewhere distal in the body, and they signal peripheral inflammation or other noxious stimuli, and they relay that through the dorsal root ganglion into the spinal dorsal horns. These signals are then transmitted upstream to second-order neurons, and they eventually make their way up to what's called the trigeminal nucleus caudalis, or the TNC, within the brainstem. So here on the left in this image, you can see a mast cell and its mediators triggering the nociceptive activation, and then that nociceptive activation working through the dorsal root ganglions and working their way up to the brainstem and the trigeminal nucleus caudalis. This trigeminal nuclear complex, which includes the trigeminal nucleus caudalis and also some additional neurons at the C1, C2 level, those are their related extensions, they then send afferent signals to other second-order neurons in the central nervous system or in the brain. This signaling is often through release of trigeminal neuron substance P, or as you might be familiar with recently in migraine literature, calcitonin-related gene peptide. It should be CRGP there, acting upon, so these substance P and CGRP act upon meningeal vessels of the trigeminovascular system, and they also act upon, interestingly enough, dural mast cells. And this activation then triggers the propagation of both migraine and of central pain sensitization. So here on the right, you can actually see this is from literature on CGRP antagonists in migraine, and binding to CGR receptors both on meningeal vessels to block that vasoactivation of the trigeminal vasoactive system, and also on mast cells, preventing mast cell mediator release in the brain can be very effective at reducing central pain sensitization, and particularly migraine incidence or propagation during migraine. So just a kind of an example of how something can be triggered. We think about migraine triggers, whether it be things that we eat. Oh, this has a lot of MSG, or chocolate is a trigger. It's possible that it could actually be through this mechanism and some mast cell hypersensitivity or mast cell activation that we see these type of responses. So what do we do now in our clinic that we've identified patients with mast cell activation, either from long COVID or that they have it independently? Well, there's really a lot of options for our patients. I think it's important to look at the first two bullet points here, a low histamine diet and diamine oxidase. So diamine oxidase is actually a supplement that people can find, maybe not at their local drugstores, but very easily on Amazon or other large marketplaces. And the idea here is to reduce the intake of histamine in the first place, which is really not a part of our mast cell activation pathology that we've discussed thus far, but seems to make an enormous difference in actually that histamine triggering activation of mast cells in that local GI tissue and then propagating their signals elsewhere. Low histamine diets are extremely restrictive and hard to be compliant with, but when I've seen a patient that has had good responses with low histamine diets, I'll often get them started on diamine oxidase that they'll take with their meals, and they find that they can start to tolerate things that they used to think they had food allergies to. Of course, H1 and H2 blockade can play a very big role in this, and we're all familiar with drugs like fexofenadine, loratadine, cetirizine, and levocetirizine. They're easy to get, they're usually not expensive. And then don't forget the H2 blockade with famotidine. In particular, ranitidine has had some manufacturing issues of recent, and cimetidine is one of those no-nos when you're on any other drug as it relates to liver processing. But H2 blockade can be particularly effective. Diphenhydramine, when not too anticholinergic and when not too sedating, can be helpful. It certainly can be helpful in a pinch. When there's an episode, early in the episode, you'll see people respond well to taking Benadryl early. And don't forget that when people go to, say, an Instacare for migraine relief, that migraine cocktail has always had diphenhydramine, IV diphenhydramine in it. And I do wonder if part of the reason that that got included was because of its ability to decrease histamine levels as it relates to migraine propagation. Leukotriene blockade through montelukast is an effective tool, particularly for people with pulmonary symptoms. There is a black box warning on montelukast now that a small percentage of people will see an increase in depression. So just be sure to let your patients know that that's possible. I like to hit people hard and fast with mast cell stabilizers myself. I just think that they, by using a mast cell stabilizer and seeing a response, you're really kind of making a clinical diagnosis, even if you can't get those serological or urine markers. They're just maybe a little more effective in my experience than just H1, H2 blockade alone. So I will often use things like compounded cromolyn sodium, which I get from a compounding pharmacy. That's at a dose of 200 milligrams PO/TID. Compounded ketotifen, which is both a mast cell stabilizer and an antihistamine at 1 milligram PO/BID, is very effective. It's a little cheaper than the compounded cromolyn sodium. It can, I'd say, in maybe 1 of 8 people lead to a little bit of daytime sedation, but usually is tolerated better than Benadryl in that sense. Over-the-counter quercetin can be helpful. And then there's also liquid cromolyn or gastrocrom that we give. It comes in these little 5 ml vials with 20 milligrams per ml. And I'll usually have people take somewhere between 2 to 2.5 mils 15 to 20 minutes before they either take their medications or before they eat. It's very difficult to be compliant with. But when people do start doing it effectively, it can make an enormous difference on GI triggered mast cell activation. If the trigger is not in the GI system, the systemic absorption is maybe not quite as good with the liquid cromolyn, and that's when I'll switch to or use in combination the compounded cromolyn sodium. I have even seen situations where patients are given compounded cromolyn sodium and they actually react to the capsule itself or to the medication itself before it can be absorbed and distributed in the bloodstream. In those cases, I will sometimes have people open the capsule up and pour a little bit of the powder into some small water and drink it that way. Or I may actually pre-treat with gastrocrom, calm down all those mast cells hiding out in the GI tissue 15 minutes before taking the systemic cromolyn. Then the systemic cromolyn is not reacted to, it is absorbed, and you start to get the systemic benefits as well. I reach for that systemic cromolyn in particular for patients with migraines or other patients where I think neuroinflammation is playing a big role in their symptoms, particularly if I think there's some craniocervical instability going on as well, although there will be a follow-up lecture on that in the future. One other thing, and this is where you do need to get your allergy immunologist involved, is if you want to use an anti-IgE biologic such as Xolair. Xolair can be particularly effective when all other mechanisms are not working, but I have rarely had to reach for this to get people under control. And again, this is just a reminder that empiric trials of therapy with a clinical suspicion of MCIS can be diagnostic, and that's often how I practice in the outpatient setting when it's really hard to get this laboratory testing done correctly. One other thing I would comment on that is not on this list of treatments that you'll see from our allergy immunology friends is allergy desensitization shots. That is a long, arduous process and is, in my opinion, a bit of a fool's errand in trying to chase very specific triggers, realizing that there are all kinds of multiple triggers and they're changing all the time in a patient with mast cell activation. So that is not something I pursue or recommend for our patients. And that is all I have for today.
Thank you, Dr. Yeoman. Will you actually leave that last slide up, please, just so folks can take a screenshot if they want to. We have a couple questions in the chat, and we will open this up now for Q&A. We do not have a specific patient case, so feel free to open up your questions a little bit more than maybe we would have in the past. To start, and this is for you, Dr. Yeoman, as well as the mentor panel. How is mast cell activation associated with psychiatric manifestations?
So I think when we talk about psychiatric manifestations, we have to define, are we talking about independent illnesses like depression or anxiety, or are we talking about maybe sympathetic overdrive mediated, PTSD-like mediated psychiatric manifestations? In the latter, which we do see in our long COVID patients, it's certainly true, I think, in many cases that when we control mast cell activation using these treatments, that we will see people's sympathetic overdrive also improve. And I don't know if that's because they're under less physiological stress from the vascular manifestations, from the, you know, the vasodilation and facial flushing and things that we'll see there. It may also be that they're in less pain from less local tissue inflammation or less migraine, et cetera. So there's certainly an association there, but I am not aware of any direct impact on things outside of that sympathetic overdrive realm.
Dr. Brown or Bateman, do you have anything you'd like to add? Okay, so the next question we have here, I've been told that elevated serum PGD2 is not a valid indicator. Can you comment?
So that is not something I have heard or been told. I'm not sure where that came from, but it is definitely part of the current guidelines for clinical diagnosis of mast cell activation. Again, in my clinical practice, I try not to get too obsessed with proving mast cell activation. It's different if you're trying to enroll people, of course, in a clinical trial, right? But if I know that the risk factors are there, if there are other comorbid conditions there, if these are symptoms that started after COVID infection and have persisted despite resolution of the main COVID manifestations, I will again just start empiric treatment and not get too bogged down in the prostaglandin levels.
I just wanted to make a comment. This is always a little bit controversial about whether you stick by strict evidence-based guidelines before you initiate treatment, or if in a primary care setting, you have a little bit more flexibility. And the way I look, I'm pretty conservative about the way I practice, but what we've learned in our post-viral syndrome population and our Ehlers-Danlos or our hypermobility population, and now in spades in long COVID, something that appears to be mast cell activation tends to be very, very frequent in our patients. And, we're looking for ways to, without causing harm, to intervene and help with supportive care very early in long COVID. And I would say that our experience in the long COVID clinic is that patients respond to mast cell activation treatment when they have a clinical picture that is suspicious or suggestive, and it's pretty inexpensive, pretty safe to do, at least especially the primary mast cell activation interventions. And it's, we try to get the objective markers if we can, but they're hard to get sometimes. And especially if your patient is really symptomatic, because it's hard to get them off all their meds. It's actually not even safe, maybe for people who have a lot of allergic responses going on and need to stay on their antihistamines and their other medications. So I've become a lot more liberal in thinking about this as a multi-system illness presentation that's relatively common. Doesn't mean it's permanent, right? It may be something that people can move through, but it has been really gratifying to put that in our list of differential and way to provide supportive care.
And I agree with that too. The low histamine diet, from what we've heard from a lot of patients, some patients have good success with it, but like Dr. Gelman said, is very hard to adhere to. And, it just depends on, what people have found sort of helpful. The one thing as a pulmonologist, being able to get biologics is hard. I can't get it for asthma patients half the time that qualify. So it's just been one of those challenging things, I think, when you kind of escalate to some of those patients. But because I wasn't sure, I honestly don't off the top of my head for Xolair if it has FDA indication for mast cells activation syndrome.
I don't believe it yet does. I think they're working on it, Dr. Brown, but I have seen allergy immunologist physicians prescribe it for that purpose. They seem to be able to get it approved. I've tried it myself and I can't get it approved. I tried to pretend I was using it for Churg-Strauss as a rheumatologist, which it also has an indication for, but didn't work for me.
No,
in that case, it's important to remember you do have to have an elevated IgE level for it to be approved or effective.
Just to keep kind of going with that same question, do you tailor therapy to symptoms? Also, use of ASA or other NSAIDs for elevated PG2.
So I definitely tailor therapy to symptoms, right? If I think that they are primarily suffering from GI mast cell activation, then I will often consider something that is GI specific, like the gastrocrom we were discussing, or low histamine diet, diamine oxidase. Sometimes, interestingly too, and we didn't mention this in the lecture, but I would say I'll find that people aren't responding like I would expect to other oral therapies. And sometimes you'll find that they actually have their absorption of medications is somewhat mitigated by that local inflammatory milieu. And so you'll start to see responses to medications that maybe they weren't responding to as much as you might think once you initiate GI therapy. So I'll definitely target that. If I think people have, craniocervical instability with secondary mast cell inflammation and pannus at that CCI site, or migraines that I'm trying to treat, I'll often use systemic cromolyn because that seems to, at least in my experience, have the best neurological penetration and activity. And so I'll often see that people's responses to migraines or their headaches when the barometric pressure changes tend to improve with systemic cromolyn. If people have primarily pulmonary manifestations, I can reach for Montelukast. So I do try to tailor it to some degree. I have not used any low-dose aspirin for the elevated PGD2s. I think that that's sort of a downstream type intervention, right? Which I guess is no different than what we're doing when we're using antihistamines or anti-leukotrienes. But I personally, just in my style, not that this is right or wrong, but like to try to go a little more upstream from that and prevent the actual activation of the mast cell in the first place. And in my mind, I do that because it's one thing to block local tissue histamine release. It's another thing to block activation of the mast cell in the first place so they can't send signals through the neurological system to other upstream areas or to other areas of the body. So I do tend to reach a little earlier in general than most people for those mast cell stabilizers. I do not, however, I haven't used aspirin in that circumstance. It might be reasonable, especially if you have somebody, with a history of vascular permeability issues or microclots related to their initial COVID infection. It's certainly something to consider, though. And it looks like Dr. Bateman may have used this or has some comments.
Actually, my comment isn't specific to that question. It's just something I'm sitting here thinking about. If this is a really odd concept for you to think about mast cell activation, the things that really helped me were thinking beyond upper and lower airway. We're all used to managing upper and lower airway allergies, right? It's kind of a no-brainer. So that's going to come up in the history, you kind of know what to do. But what started to stand out for me in our patients, not just long COVID, but especially in long COVID, but in all of our ME/CFS patients, is skin manifestations. Sometimes people don't bring up the things that are happening with their skin, but it's kind of weird to get hives, right? And if they can say, oh yeah, I do this and I get hives, or you can ask about skin manifestations. And then there's a lot of people who develop GI symptoms after COVID, and they don't really meet criteria for anything. They just have poor tolerance of a lot of different foods. And then of course, we're just seeing dysautonomias and POTS, and it's a big number of our patients are POTS related orthostatic intolerance syndromes and tachycardia. So if you think about it, technically you only need 2 systems, but if they've got it in 3 or 4 systems going on, you should really think, is this a possibility, right? And how would I target histamine receptors in those systems? And that would help guide, what you decide to try treating with.
So then, Dr. Bateman, you teed this up perfectly. Do you find that using these stabilizers will help their symptoms of POTS?
Yeah, I had a patient who, this was long before long COVID, but a patient that convinced me, she drew a graph of her heart rate response standing up on when she added what it did normally and what it did when she was taking Zyrtec, cetirizine. And it just, in her particular case, it just eliminated her tachycardia to be on an H1 blocker. So, and I'm going to say there's a lot of heterogeneity in the presentation of this illness, but that made me a believer a long time ago. So I try to, put that in the differential in people who have not only a dysautonomia, but also have these, a different system involvement after their post-viral syndrome. This fits in so well with what we think about long COVID, which is we just aren't sure if the pathogen is still there, or maybe there are remnants and DNA fragments and antigenic triggers, that it's mostly an aberrant immune response that keeps grinding. And this is a pretty straightforward way to start to impact that, at least in the arena where we have this information.
And there was another question that asked, would it be reasonable, advisable, considerable to place select patients on mast cell activation treatments empirically on COPD exacerbations? So they've looked at COPD for a long time in different cell populations. The 2 that stand out are eosinophilic, and that's the one where you see a lot of the allergic symptoms. There's actually those pretty severe folks that have more of a neutrophil predominance, and those ones don't respond. I would say I wouldn't necessarily rely on anything mast cell specific though for a known COPD exacerbation, just because those mechanisms are so well known. I don't necessarily think it would be a bad thing because, to add on some of these meds, because they also affect eosinophils, which we know are part of that pathology, but I don't know if I would hang my hat on mast cells for that one.
Well, and there's one treatment that is often prescribed for COPD exacerbation that will also affect mast cells, and that's prednisone.
Steroids.
So there's another question in the chat box, and I kind of want to, I have two questions that I'd like to ask. So Jessica, I'm going to save yours for the very end. As we hear more about patients with long COVID, ME/CFS, and these defining characteristics of PEM, which we discussed a couple lectures ago, do you find that unmanaged mast cells can lead to post-exertional malaise? And how do you really tweeze out what is PEM, or is simply treating empirically and then seeing if those manifestations improve enough evidence to say mast cell can be driving PEM?
I'll take a crack at that. I will say that I think it's a bi-directional pathway, really. Post-exertional malaise is this altered physiological state where all of your symptoms are worse. And you definitely see that people with underlying mast cell activation at their baseline state will have much worse symptoms of mast cell activation when they're in PEM. So when I'm assessing people in clinic, I will often try to determine if they're in that push crash cycle, if they're having more bad days than good days. And if I've started some empiric mast cell therapies and it's not sufficient, I question whether the next step is to keep escalating therapy or to instead try to help those patients pace better and get out of that push crash cycle. Sometimes when they get out of the push crash cycle, their mast cell activation improves enough that your traditional therapies, whether it be mast cell stabilizers, H1, H2 blockade, are enough to generally control their symptoms. And does mast cell activation contribute to post-exertional malaise? Well, certainly it exacerbates other triggers for post-exertional malaise. If you have worsened orthostatic intolerance, worsened sympathetic overdrive, more pain, more anxiety, more migraines, it is more likely to be a drain on your overall energy envelope and potentially trigger PEM. So I think it's possible, and I do try to manage it with the idea that everything that I try to do to manage long COVID or ME/CFS at the end of the day kind of boils down to trying to avoid PEM. But it is a little more targeted and focused at their day-to-day symptoms as well.
Okay, then I'm going to ask the last question here. Do you have tips on how patients could introduce MCAS to their family physicians, as it is not well known? We know patients have to advocate for themselves, so are there supplemental materials they could bring forward to facilitate testing and treatment?
One thing is they can send their primary care doctor to watch this recorded echo program down the road.
Shameless plug.
I mean, I would say, so my background is in immunology. That's what my PhD is in. And one of my challenges with the mast cell activation literature is the specificity. I think that's why the medical community has been somewhat slow to uptake some of this, is because we all know that correlation isn't necessarily causation. So I think one of the challenges is the research is not up to speed. That being said, it really is terrible when you have a patient in front of you who's suffering and you want to do something about it. So I think that's where we are with a lot of long COVID things, is this spaghetti method to some degree, which is throw stuff at the wall and see if it sticks, and try to do that based on the best science and data that's available. But it does not surprise me that it is not yet uptake by a lot of people, in a wide way. Unfortunately, COVID is the gift that keeps giving, and maybe in some ways it'll be better because this will fuel a lot of patients and better research. But I just sort of be prepared for that. There is some decent resources like with the slides that Dr. Yelman was showing, but there are just times where I think mechanistically there's a bit lacking out there. And so, but again, I think it comes down to what Dr. Bateman said, though, which is, harm benefit calculation and discussing those things. Antihistamines, probably not going to hurt people. Cromolyn, probably not going to hurt somebody. Xolair, we might have to think about that one, because it's not completely benign either. So I think that's just for you. And like we were saying, is this the right diagnosis? Which can be super challenging for these patients. So I think it's great, when patients have done their own reading and bring resources from credible sources. I think that's helpful.
Well, not only that, but as Dr. Bateman had suggested, if your patient is on cetirizine and you have empiric data that your heart rate isn't elevated, I mean, a lot of these things you can advocate for yourself, right? You can take over-the-counter antihistamines, over-the-counter Benadryl, over-the-counter, quercetin, for example. A lot of this stuff doesn't require a prescription. So try it yourself, see if you respond, and then take that data to your treating physician and say, hey, I'm responding to this, but I need a little extra and I have long COVID. That can bolster the data that you bring in as far as publications.
I'd like to mention as a non-specialist in allergy immunology, that it's my observation that the specialty community is a little divided on this issue. And it's interesting to observe that from the outside. And that is they've kind of split into super conservative, only, really tight diagnostic criteria. And then on the other side, a group of specialists in allergy immunology who are saying we've defined this way too tightly, and we really ought to loosen these and see that the impact might be happening to a lot of people. That's one thing I would say. So if you're going to read, don't just read one thing, right? Because there are actually two sets of guidelines out there, one set from the conservative group and one set of guidelines from the more liberal group. Ooh, I didn't mean to talk politics. Anyway, the other thing, my thought is, it's possible this isn't exactly mast cell activation syndrome, but that mast cells are getting activated as part of the larger immune response. For example, we see a lot of elevated histamine levels, which are not specific for mast cells. But in my rationale, if there's elevated histamine, antihistamines and things that reduce histamine release are still appropriate. And one example is I was working a patient up for mast cell activation, and she got acute COVID and didn't know it. And she was developing acute COVID on the day that she went in to have her blood drawn for mast cell activation. And it came back as screamingly high histamine levels, which I think were really a part of her acute process of being infected with COVID. So I just think you have to use our common sense, right? And do no harm, but also don't withhold treatment. It's like Dr. Brown said, when you think you might be able to probe and do some common sense things that could help your patients recover more quickly from this, massive insult that we're seeing from COVID infections.
And I think that's a really important point too, Dr. Bateman, is that we might be thinking about this slightly differently in our chronic long-term ME/CFS patients and our early, post-COVID patients who've only had this 6 months or so. We do think, at least theoretically, that immune perturbation, both overactivation and underactivation of various parts of the immune system, play a huge role in the long-term development of these disabling illnesses. And could we be intervening, especially in our long COVID patients, and actually preventing some of those secondary complications by treating with relatively safe medicines early in the course of this illness? Could we even be preventing, when people get COVID, the progression to long COVID? And that's where I will make one other confession and say, when I did catch COVID a few months back now, I already have POTS. I was starting to get urticaria, as I discussed earlier. I do have hypermobility myself. You better believe I took some ketotifen there for about a month when I had the acute infection, really because I did not want to end up with long COVID symptoms. Do we have long-term data that suggests it? No, but I think it's a fair hypothesis.